All right, so this webinar today is being hosted by the Accelerating Scale-Up of Implants Project, or the ASI project, which is a 2-year project funded by the Bill and Melinda Gates Foundation and managed by Jhpiego. The project fast-tracks efforts to introduce and strengthen high-quality family planning services by building capacity, improving health providers' skills with implants, and providing an enabling environment for select countries to scale up implants or contraceptive implants more widely. Some of you joined us for the first webinar of this series, which was held back in early October. And at that time, we introduced the ASI project and the Implant Access Program initiative of the Gates Foundation in greater detail. So I hope you were able to join for that. We also showed you the newly developed Contraceptive Implants Learning Resource Package, which you'll see on the screen now. This Learning Resource Package, or LRP, is a training package designed to serve as a resource for the growing need to train providers on implant service provision. And following the overview of the LRP that we did on the webinar in October, we're now delving into some of the more specific aspects of implants provision, which follow the format of the LRP itself. The impetus for today's webinar, which might not be surprising, comes from Chapter 2 of the LRP, which covers counseling. I also want to make an important note, and that is that though the LRP focuses specifically on implants, the sessions today are applicable to all family planning methods. I think obviously when it comes to informed choice in counseling, we want to ensure that the entire array of available family planning methods is what's made available or what's counseled to our clients. So today we have 2 presenters. Our first presenter is Trish McDonald, who is a Senior Technical Advisor at USAID, and she will speak about informed choice. And then after Trish, we'll hear from Charity Ndwiga, who joins us from the Population Council's Nairobi office. And Charity will talk about the Balanced Counseling Strategy Plus, which is a tool developed by the Population Council and used by family planning programs and providers worldwide. After both presentations, we'll open the floor to Q&A, and as indicated, what we'll do is you'll be able to chat your questions into that chat window that I had introduced you to down in the bottom right corner of your screen, and then I'll go ahead and moderate that session. Note that we're also joined by Jhpiego's Director for Family Planning and Reproductive Health, which is Dr. Ricky Liu, and he provides oversight for our technical oversight for our ASI project. As well as Elaine Charot, who's our ASI project director. So we may draw on them during the Q&A as needed. So with that, I'd like to introduce our first speaker. Trish McDonald is a Senior Technical Advisor at USAID, supporting the Evidence to Action, or E2A project, and the Maternal and Child Survival Program, or MCSP. She is a highly regarded champion for the integration of family planning and maternal and child health, or FPMNCH, and for expanding contraceptive choice to include long-acting reversible contraception, or LARC, and permanent methods, PM. She has over 30 years of experience in the design, management, and implementation and evaluation of family planning and maternal, newborn, and child health programs, and has field experience in over a dozen African countries and lived in Indonesia for 10 years. Ms. McDonald is a registered nurse with a Master's of Public Health from the University of Michigan. So with that, Trish, I'll ask you to unmute the mic and we can get...
Great, thank you, Megan. And let me start by welcoming everybody and thank you for calling in and participating, whether it's early morning where you are or later in the evening. And start off by wishing you all a very happy new year and all good successes for the coming year in 2015. I'd like to let everybody know that I'm just recovering from a cold, and so if I sound a little congested or need to cough or something, I may mute my speaker, take a drink of water, whatever I need to do. So I want to apologize in advance for that. But I'd like to start by saying how pleased I am to be a presenter in this webinar. It's really helping advance the role of counseling and the importance of counseling. one would say that counseling is really at the heart of family planning, and it is what family planning is all about in many respects. Um, Certainly, this is true for programs that offer client-controlled methods such as condoms, diaphragms, cycle beads that really require those clients to take and initiate the use of those methods. As well as for some of the short-acting methods, like pills and injectables that require little or no provider skill, other than perhaps an injection. And yet clients may need quite a bit of counseling or information to correctly and effectively use the methods that they've chosen to use. While I've long been involved in expanding access to long-acting reversible contraceptives and permanent methods, where substantially more clinical skill is required, the longer I'm at it, the more and more I really appreciate the importance of counseling and how that must always remain at the heart of family planning for clients' care and services. Next, Megan. Very briefly, an overview of what I'll be touching on today is the goal and some of the concepts of counseling, contraceptive options, looking at and asking the question, how much choice is too much choice, and how do we address that? Counseling is ideal, but is it really operational at the level of quality that we hope can be attained? And then finally ask a few questions about where are we headed. Next. So with the goal of counseling, we're looking at helping women, men, and couples to choose and correctly use a contraceptive method that fits their reproductive desires, their lifestyle, and their health status. And by reproductive desires, we're talking about delaying, spacing, limiting, also providing counseling around the benefits of healthy timing and spacing, and ensuring that all women and couples have the right to choose the number of children they desire and when to have them. When we look at issues around lifestyle, not every method fits every woman or man, couple, and their lifestyle. Some have infrequent sex. There are a lot of social and family considerations, the desire to sometimes hide the use of a contraceptive, people living far from health services, income and poverty levels that affect what people can afford to pay for contraceptives, things like that. So all of those lifestyle issues. And with regard to health status, this is where we often look at the medical eligibility criteria from WHO. And while most contraceptives can be safely used by most clients, this really refers to any conditions for which the risks of using a method would outweigh the benefits, and therefore should not be used, or should be used under perhaps greater monitoring or follow-up. So this may include, for example, women who are HIV positive taking certain medications, postpartum women for the timing of initiating a method. Next. So underlying the counseling is, of course, rights-based counseling, in the sense that all people have the right to choose and decide freely whether or not to practice family planning. All people applies to adolescents, married, unmarried, women, to men, to HIV positive, to people in all walks of life. The family planning program should provide unbiased information, education, and counseling. In other words, clients are not being pushed into using particular methods. They should be able to obtain the method they choose if it's available and there's no contraindications to its use. They should also have the right to decide when to start, stop, or switch methods. Simply because somebody's using a long-acting method doesn't mean they have to use it for the full duration of its effectiveness. It can be removed whenever they want. Clients should be able to have confidential discussions with their providers They should be able to freely express their concerns and their views and provide feedback to those providers. And as well, all family planning services should be respectful of all clients. We do see that in a number of areas, this is really a big emerging area in maternal health is respectful care, and it extends into all the kinds of services that we do. So irrespective of the client's age, marital status, religion, etc., all clients should be treated with full respect. Next. Informed and voluntary choice by the client is the platform upon which certainly all USAID supported programs and hopefully all family planning programs in the world are based. This really means that it's client-centered. The client has the right to make a choice that is based on full information and freely choose the method that he or she wants. Two of the more effective ways of providing information and helping with voluntary choice is through counseling and health education. And I want to draw the distinction between both of them. Health education really provides more of an overview or an orientation to the contraceptive methods and some of their characteristics. It may often be done in large group settings or through IEC types of materials or media, while counseling, on the other hand, is more of an interactive process in which the client's questions, needs, concerns are discussed in order to help women, men, couples choose the method that is most suitable to their lifestyle and their desires. Next. Yeah, thank you. So, informed and voluntary choice means that we have a choice of options. But when we look at what's currently available today, we really see that there are, nearly 20 methods just on this page alone. And this doesn't actually contain all of the different brands and varieties of contraceptives that are available. On the left-hand side, we see a lot of the short-acting methods, such as the pills and injectables, the natural family planning methods or fertility awareness methods with the cycle beads and the breastfeeding. We have some new methods that are coming out into the marketplace and are being introduced, the vaginal ring, the Silk's diaphragm, and methods that are still under development, such as the biodegradable implants. So, what's really interesting is that when I first began working in family planning, the methods that were most widely available were pills, condoms, IUDs, and sterilization. And now we see this very wide range, including on the right-hand side now the introduction of more contraceptive implants, and at least 3 different varieties there, the IUD with the copper IUDs as well as the hormone-releasing IUDs. So within family planning, we just keep innovating and trying to come up with better and more methods that meet the needs of potential clients. Next. All right. So it leads us to ask a question around how much choice is too much choice, or how much is just enough choice. Recently come across some of the behavioral economics studies that are being done, and a very interesting article that was published by Jack Stevens and Elise Verlan called Applying the Principles of Behavioral Economics to Promote Long-Acting Reversible Contraceptive Methods in the Journal of Perspectives on Sexual and Reproductive Health. And what it does is really looks at a lot of the key principles of behavioral economics and how we might apply some of these to family planning, particularly when it comes to choice. Now, albeit this particular article had a lens on long-acting methods. Some of these principles we can see very clearly how they would apply across the board to all contraceptive methods. So they grouped these into a couple of categories. One was kind of looking at what's the optimal number of options. How do people make choices when they have a lot of options? So the first principle that they identified was default. And this says that the manner in which the options are presented influences the success of the intervention. And they present an example of opt-in and opt-out programs, where opt-out programs give people the automatic choice. It's there, that's the default, and they have to choose to leave it as opposed to opting in. And they've seen greater success with those types of programs. So for family planning, what we could imagine that the order in which family planning methods are presented can influence their use. For example, the first methods mentioned could be presented as the default, and these are often the ones that are selected by clients. We do see in a lot of the counseling or IEC types of materials where the order is presented from condoms, pills, injectables, and moving up the ladder towards the longer acting and permanent methods. So does that lead clients to choose more within those methods that are presented first? Could the order be flipped and present by order of effectiveness? So taking things by category and presenting, for example, the most effective to the least effective, or duration of effectiveness, based on those criteria that are important to clients. The second principle pardon me. The second principle, choice overload, says that too much choice can result in no choice being made, or clients not being fully satisfied or confident in their choice because there's just too much to choose from. So when we look at this whole group of methods that was presented, if all of those methods are presented, it can be very overwhelming and overloading for clients. And so again, what do we need to do to narrow the field of choices that will help clients choose ones that are most in line with their needs, and therefore lead to greater satisfaction and use by those clients. And the third principle that they identified is called compromise effect. And this basically says that when people are presented with three choices, they have a tendency to select towards the middle. So if this were to be applied to family planning, we could look at things like offering pills which need to be taken daily, injectables which need to be taken quarterly, or a long-acting method that might be good for 3 to 10 years. This principle would say that presented in that manner, people would be more likely to choose an injectable. The same would be true if they were offered an injectable, a 3 to 5 year implant, or a 5 to 10 year IUD. They may be more inclined to choose an implant. This has not been studied. I want to say that this has not been studied in the area of family planning, but it's kind of taking that principle and seeing whether this might apply in a family planning setting. Next. So the next group of information that the authors looked at was how might information be presented optimally. And in this area, they had identified 3 additional principles. The first one is framing, and it refers to the impact that different presentations of the same information can have on consumer attitudes. And they give an example that in the medical field, both clients and physicians are more likely to accept a treatment option if it's positively framed. In other words, if it's associated with an 85% 5-year survival rate compared with a 15% 5-year death rate. And so clearly that has implications for how we present family planning information. We might talk more about the benefits rather than the side effects. Talk about client satisfaction and continuation rates rather than discontinuation rates and dissatisfaction. The second principle, present bias preferences, reflects that consumers want to enjoy benefits as soon as possible, to minimize costs in the near term, and to defer costs to the long term. The example they give is for the use of LARCs. This might actually run counterintuitive to this principle because the benefit of delayed pregnancy prevention is really a long-term benefit, while the upfront costs are often high. So one of the things that family planning programs could consider is how to provide some more immediate benefits and reduce the costs, such as integrating with immediate postpartum care so that all the services is provided at the same time. There's no need for a follow-up visit. Costs may be able to be minimized or subsumed within the birthing costs. Or other services can be integrated with the provision of those methods, such as cervical cancer screening with IUD provision, so that there are some other immediate benefits that can be accrued. And then the third principle of social norms is one that we're all familiar with, and basically posits that when social norms, more people are using it and like it, and others know about it, it increases acceptability. And this can have a very powerful impact on client choices. We see this in a number of programs, and one that I'm very familiar with in Mali is a very interesting one where LARCs were introduced. It was first done in immunization sessions where the program could reach many women at one time. And through group discussions, the women were presented with positive information about all contraceptive methods, including very positive information about IUDs and implants. They were also offered same-day services. And from the first day, 10 to 15% of women who were attending the immunization sessions asked for counseling and or the methods themselves. And since this was done on a weekly basis, it kept reinforcing very positively these messages. And pretty soon we began seeing women without babies coming to immunization sessions simply because of word of mouth, very positive presentations by satisfied users. And in just a couple of years, LARC use in Mali went from 0.3% of the method mix to 25% of the method mix. Next. So with so many choices, what we really need to think about is how do we organize the information? What's out there that can help providers to organize and present information, as well as what's available to help them make choices. Today, Charity is going to talk more about the Balanced Counseling Plus strategy, which uses a set of algorithms to help elicit clients' needs and preferences. And you know, we've also seen this chart of effectiveness and how methods can be grouped by effectiveness as a way of sort of, if clients are if that's the highest need that clients have or something that they're very much interested in, it's a way of helping to organize the information that can be presented to them around different categories of contraceptive methods. Next. So good counseling is at the heart of family planning. And good counseling is the ideal that we are all striving for. But how realistic is it? is the counseling client-centered? Are clients' needs and lifestyles and concerns being asked about, or is information simply being provided around the range of methods that's available? Some of the concerns that we hear from our programs and from providers is that good counseling takes time. And unfortunately, it's often done as health education only, or during counseling sessions. It sort of repeats the listing of the information provided during the health education and asking women to choose from that. So one of the goals of our family planning program should really be towards shifting counseling to be more client-centered rather than method-centered. We need to think about flipping the paradigm and starting with understanding the client and the client's needs, and framing the choices around those methods that best correspond to that. So some of the questions we have is, well, is that feasible? Will it really take more time, less time, the same amount of time? All still good questions to be asking. A second and very real concern that many countries have is a shortage of health workers. And those that are working are being asked to do more and more. One of the programs in India actually developed a new cadre of family planning counselors for their postpartum family planning program. And these are counselors who are dedicated to talking to pregnant and postpartum women about family planning options and birth spacing and breastfeeding. And according to the ministry in India, the addition of these counselors has been very successful in increasing the family planning uptake among postpartum women. But is this realistic for all countries? Some countries are using dedicated family planning providers, especially when they're providing integrated services such as postpartum family planning, or in mobile outreach, either as individuals or teams that have counselors with them and are dedicated only to providing family planning, so have the time that they can take to do that. One of the measures of success of family planning programs is that they serve greater numbers of clients. And yet, the more clients they have, the providers and the system are saying, wow, we're just doing more and more and more. So unlike disease prevention services such as malaria, water and sanitation, immunization, when they're successful, they actually have fewer clients that need treatments. Whereas with family planning, the more successful we are, the greater the number of clients that we need to serve. So, family planning programs need to look for alternative approaches for maximizing efficiency in order to reach more clients. And this would mean things like offering greater access to long-acting and permanent methods that require fewer visits to the provider for resupply, or things like increasing the role of pharmacies, community health workers, the private sector providers, so that not everybody is going to the public clinics. Next. So where are we headed? As we look at this intersection between counseling and choice and the realities faced by countries to offer high-quality, client-centered family planning counseling, and doing it with an ever-expanding range of contraceptive choices, we still have a lot to learn. We need to implement what we know works, even if it means changes to existing materials and job aids, training and supervision, and, quote, the way it's always been done. But we also have a lot to learn about how to not only make counseling better, but also how to do it within the context of very real health system constraints. So these are just a few of the thoughts that I put down here, and I really am very interested in hearing from all of you who are participating in this webinar about what some of those real concerns and areas for further research and exploration are that you have and are facing in your own countries. Clearly this issue of how to present information and with an ever-expanding range of contraceptive choices and how to help women make those choices. How do we counsel prospective clients in a way that supports and doesn't inhibit them from making choices? In other words, how do we eliminate bias in some of the way that information is presented and make sure that we're presenting contraceptive methods, all methods, in a very positive way? We need to better understand what factors are most important to family planning clients when they're trying to decide what contraceptive methods to use. Issues of lifestyle, discretion, efficacy, those sorts of things that go beyond the kind of the standard types of information that we often collect in the DHS surveys. How do we tailor counseling to the needs of specific populations, such as youth, first-time parents, postpartum mothers, post-abortion clients, limiters, method switchers? We've seen that in many countries it's easier to talk about family planning use for spacing than it is for limiting or delaying. Yet all clients' needs are important, and we need to help providers be able to feel comfortable in talking about all the different reproductive intentions that clients may have. And we need to understand from the provider perspective what their needs and concerns are and how to help them become better counselors. What do they need to do a good job? What's important to them? And of course, from the client's perspective, not only what's important to them about the choices they make, but what are their thoughts and feedback on the quality of the counseling that they're receiving, how they're being treated. Is it respectful counseling and care? So these are just a few of the ideas. I know there's a lot more out there, and I'm hoping that during the discussion session, many of you will be able to describe what issues you're facing and what are some of the areas of support that could be provided to your programs in order to make counseling really the heart and soul of family planning, informed and voluntary choice. So I'd like to thank you all. Thank you all for your participation. I look forward to the discussion following Charity's presentation. Thank you.
Great, thank you for that, Trish. I think it was really, really interesting to hear so many of those perspectives you brought, particularly about all of those particular considerations when it comes to some of the behavioral economics and what's too much choice, or what what underlying presentation issues might be affecting the choices made by clients that we don't always think of, such as you're mentioning about compromise and the order in which things are presented and how we're framing the message. So I really appreciate that perspective. And I'm also happy to see that there's a lot of activity in the chat window. I see that Nita from our own Jhpiego India team commented about when Trish was speaking of this cadre of health family planning counselors in India, and she commented that they've had a really large impact on improving services. I know that we're starting to get some questions, which is great. So feel free to continue typing your questions in, and we will we'll do those after we finish Charity's presentation. But yeah, chat them in the meantime, and I'll hold on to those. So I think what Trish has just spoken about really sets the stage well for this next piece, which is about the balanced counseling strategy, which actually was screenshotted onto one of Trish's slides. So for this presentation, I'd like to introduce Charity Ndwiga. Charity is a program officer for the Population Council, and she's based in their Nairobi, Kenya office. She has over 20 years experience in maternal and reproductive health and is a registered nurse midwife, a registered psychiatric nurse, and has her master's in public health. In the various roles that she's had at the Population Council and elsewhere, her experience has included the development and review of strategies, policies, and guidelines, performance improvement initiatives, curriculum development, facilitation of training, development of training materials and manuals, proposal development, planning, and resource mobilization. She's currently working in several MNH and FP projects, including respectful maternity care, RH and HIV integration, among many others. So with that, Charity, I think we can have you unmuted here and we can start your presentation.
Thank you, Megan. Thank you, Megan. Uh, you have said, my presentation is about the use of balanced counseling strategy in family planning consultation. And I'm just going to move on to my the outline of the presentation. I'm going to look at what BCS Plus is, why BCS Plus, what is different in BCS Plus, how BCS Plus works, and how we go about in implementing the balancing counseling strategy Plus. The balancing Plus toolkit is a practical, interactive, and client-friendly counseling approach that uses several job aids to facilitate FP consultations. This was adapted from the original BCS that aimed at improving the quality of FP consultations, and hence the use of the term BCS Plus. This adaptation was necessary to make the strategy appropriate for settings that have high HIV and STI preference. For example, the Southern, Central, and Eastern Africa. This really now comes in very well in terms of, like Trish has said, there is need for us to offer a little bit more on top of the family planning services to make the client find that they are benefiting from the family planning consultation. So why the BCS Plus? In the past, two most common FP counseling approaches have been used in many years, and these were Gather, and the other one was Ready. And Gather mainly talked about greeting the client politely, asking or assessing the client about her family planning, herself, her family members, and her general life circumstances. The T is about talking about what kind of services are available in the facilities and the FP methods that are available in that facility. And H is for helping the clients make a decision, while E went for explaining what the clients need, and R is for referring or rescheduling a visit. The Ready, for those that have used it, I know most of us that have worked in this area have used these two approaches. It encompasses the elements of rapport building for R, and the second one is the second phase is exploration, that is about exploring the needs of the family planning needs of the client. And the third one is about decision making, and the fourth, helping the client make the decision. And the fourth one is about implementing the decision. These two approaches, they were good and they have been used in the past well, but they have been found to have some limitations. And the limitations, what were these limitations? The limitations were found was that the providers failed to discuss clients' wishes because there's so much information to give. The main providers mainly ask medical questions such as the date of the last menstrual period. The providers also fail to ask the client basic questions about the client's reproductive intentions, such as whether she wants more children or whether her partner cooperates in contraceptive use. I've seen one of the questions where someone is saying that male involvement in family planning is very critical. And this is one of the limitations that was found out. Uh, More limitations include that the providers gave excessive details on most of the methods available in the clinic, whether the methods are suitable for the client's needs or not. They often tended to overload the clients with more information than they can remember, and much of the information that was given was not used. The information provided on the chosen method is usually sparse, and most of the counseling time was spent on describing numerous method options. And researchers found that clients that were interviewed after the consultation knew little about the method they had chosen. And this is by someone, Rion in 1999 and again in 2001. Now, what is different in the BCS Plus? The use of BCS Plus simplifies decision making. It responds to the client's needs and reproductive intentions in family planning counseling. It's more reliable than memory, and it is designed to minimize try and error. Because you have this job is that will remind you, that you refer to as you continue with your consultations. It also reduces the amount of recall necessary to perform the tasks. We know our providers are few, they are overworked. We need to the BCS Plus makes it easier for them to reduce the amount of the information they have to record. The BCS toolkit, the BCS Plus toolkit has three main job aids, and that is the algorithm, the counseling cards, and the brochures. And together with, and you can see on this slide, the job aids, the BCS cards, the BCS brochures, the algorithm, and the trainers, the trainees and the trainers guide. And when you use the BCS toolkit, this goes hand in hand with the WHO medical eligibility criteria wheel that actually just helps the providers to quickly identify methods that are suitable or not suitable for clients, even if the clients wanted them. Uh, uh, the algorithm, I'll just go ahead and describe the algorithm a little bit. The algorithm has 4 stages, and each of these stages has several steps. Starting from the pre-choice stage, this has 6 steps. And in this, the other stage is the method choice. It has 3 steps. The post-choice stage has 3 steps, and the systematic screening for the other services has 7 steps. I'll take a little bit of time to describe this in a little bit of detail. So the BS Plus is divided. The strategy assumes that the motivation of the client visit is for family planning or the consultations, and may have been in another, or may have been another reason that has resulted into family planning. The BCS integrates PNC counseling messages for the mother and the infant. It also discusses health timing and spacing for pregnancies, STI, and the cervical cancer screening. Looking at the pre-choice stage that has 6 stages, the first thing that you do in the consultation is you try and establish and maintain a warm and cordial relationship. You inform the client that there is an opportunity to address uh, her health needs after the family planning needs are addressed. You ask the client about her current family size, current contraceptive practices, and you counsel her on health timing and spacing. And if she's currently using a method and she's satisfied with it, you ask whether she would want to change or if she would like to continue with it. The next step is that you rule out pregnancy using the checklist that is developed by FHI that is used to reasonably be sure that the client is not pregnant. You ask after that, you ask the following questions, and you set aside the method cards based on the current responses. The first question you ask is that, do you want to have any children in future? And if they said yes, you set aside the vasectomy and tube ligation cards and explain why. This is self-explanatory. She wants more children. So if no, you keep all the cards and continue. The next question you ask is that, have you given birth in the last 48 hours? If yes, you set aside the combined oral contraceptive pill and the combined injectable implants. And you explain why. If no, you continue with the next question. Then ask the client if they are breastfeeding an infant that is less than 6 months old. And if yes, you set aside the combined oral contraceptive pill and the combined injectable cards and explain why. If no, or she has begun her monthly period, again set aside the lactational amenorrhea card, that is RAM, and explain why. The other card that you want to, very important that you want to, the other question that you want to ask at this stage is whether the partner supports her in family planning. And if yes, you continue. If no, you set aside cards on female cordon, male cordon, and standard-based method, and withdrawal method as well, and explain why. And we know that these types of method requires that the partner is supportive of the use of family planning method. You move on to asking questions and ask that if the client has any medical conditions or they are taking any medication, and if yes, ask further about what conditions or medications they are on, and refer to the medical eligibility criteria and the national guidelines, and set out all the cards that are contraindicated with the method. This is where the medical eligibility criteria becomes very critical. Therefore, you will not go ahead explaining methods that are not going to be used by this client because the contraindications exist. Then you also ask the question if there are any methods that they do not want to use or have not tolerated in the past. And if yes, you set aside these cards. As you can see, you are going on eliminating the cards, and if no, keep all the cards. At this point, now the cards that are remaining are those cards that on the method the client is most likely to use and to select from, and that are suitable for her, because we have eliminated the issues of breastfeeding, the issues of medical conditions, the issues of whether she wants to have more children, and so on and so forth. So the next stage is the method choice stage. And this, according to the algorithm, is from stage 7 to 9. And this, you briefly review the methods that have not been set aside and indicate their effectiveness. You then arrange them in order of effectiveness, and usually this effectiveness is on the back side of the card. And in order of effectiveness, starting from the lowest to the highest, briefly review the attributes on each of the method cards, and ask the client to choose the method that is most convenient for her. You have just briefly reviewed the methods that could be appropriate for her. Then, using the method specific brochure, check whether the client has any condition for which the method is not advised. And then you review the method not advised in the brochure section. And if the method is not advisable, ask the client to select another card from the remaining cards, and repeat this process again from the previous step, that is step 8. At this point, the client has actually chosen a method of family planning, and you now, if she has chosen a method of family planning and you have actually reviewed and you have seen that this method fits her, you then move to the post-choice stage. This stage also has 3 steps, and at this stage, you discuss the provider discusses the method chosen using the brochure and give the client the complete information about the method she has chosen. And if the client has a condition where the method is not advised or is not, or the client is not satisfied with the method, then the provider will return back again to stage or the method choice stage and start all over again by briefly reviewing the cards that are still remaining. And at this method, this is what happened. You discuss the chosen method with the client using the brochure and determine the client's comprehension and reinforce the key information. Then you encourage the client to involve the partner in decision making if they are there, and you then move on to encouraging you then move on to the systematic screening for other services. And during this stage, you use the information that you had collected previously and targeted questions to determine any additional services that the client may need, and also any additional counseling that the client may also need. And using the remaining cards you offer, the provider may offer or refer for services such as postnatal care, screening for cancer of the cervix, either using VIV or pap smear, or STI and HIV screening, and HIV counseling and testing. With all the methods that are chosen, ensure that the provider must ensure that they discuss dual protections and give a return date. How do we implement the BCS PRAS training? You use the BCS toolkit for standard training, and like I had shown in a slide earlier, this includes the trainer's guide, the trainee's guide, the cards, the algorithm, the counseling cards, the method brochures, and the make wheel. The BCS PRAS training can be offered as a standalone training, and this is usually planned for 1 day. The trainer's guide has that, has a schedule on how that is conducted, or this can also be a part of a comprehensive family planning training. Any training on BCS should be followed up with periodic refresher training, and on-job training, and superficial visits. And that's the end of my presentation. I wish to thank all of you for allowing us this opportunity to present the BCS PRAS toolkit, and as part of the many tools that are used in family planning information and giving and consultation.
Great, thank you so much, Charity. I think it was, it was really helpful to hear about this specific tool that can be used in counseling, and a tool that really is focused on informed choice and addresses some of those considerations that that rose in Tricia's presentation. Excuse me. I hope that some of you who are participating have had the chance or the opportunity to see the BCS or the BCS Plus in action. It's really quite phenomenal to see how it's how it really allows the client to select the method that's best for them. And it's a more of a collaborative process between the provider and client. So right now it looks like we're about 3 minutes from the initial end time of the webinar. However, I do recognize that we had offered time for Q&A, and I'd like to honor that. So for those of you who are able to stay on until it'll be 8:45 a.m. Eastern, so an extra 15 minutes, I think we can safely secure that time. So please go ahead and do continue to type your Q&A into the chat screen, and we will try and address those. So I'm going to start with the first question that we received from Jane Wickstrom, and Jane is from Engender Health. And she asked, how do we incorporate male involvement in choice, since men are often barriers in family planning use. And so maybe if I could pitch this one over to Trish and see if she has some thoughts to add on that. I don't know, Trish, do you have any thinking on male involvement here?
Well, it certainly is a very significant and important component to family planning counseling and also to choice. If we were to look at some of the behavioral economics, one of the things that and also within the balanced counseling plus strategy, what are we really doing to try and identify what's important to men around contraceptive use? Is it around spontaneity and pleasure? Is it around the health of their partners? Or is it around social perceptions like fidelity or infidelity? And sort of figure out how we can begin to address those issues through information, social norm, things that begin to address social norms and incorporate men into counseling. I would kind of like to throw this one open to participants on the call to see, what has been taking place in countries and what are people finding that approaches that are being used that may have greater success at reaching men and helping them feel comfortable around family planning use, either by themselves or their partners. And certainly the whole issue of gender involvement and gender roles within family planning is critically important. And as we're trying to revitalize some of the male methods like vasectomy, really better understanding what it is that's important to men, what motivates them, is really going to be an important part of how we better reach men. Jane, I don't have any silver bullets on this, and every context, culture is context specific. And a lot of times it's sort of addressing those social norms and being a little bit more open and developing a comfort level around talking about the benefits of family planning in ways that resonate with both men and women, as well as families and societies.
Thanks for that, Trish. And we'll see if people start typing some of their thoughts into the chat on that, then I can go ahead and share those with so the next question I want to take, this one I'll pose to Charity. This is from Durba, who I believe comes from the CCP India office. And Durba asks, how do we deal with myths and misconceptions related to methods, because these travel faster than the positive information, which is a really interesting way to pose that. So I don't know if Charity, if you want to talk a little bit about how you deal with those myths and misconceptions.
Correct. The way we deal with myths and misconceptions in family planning is when, I don't know whether you have looked at the BCS cards, they provide the correct information about what a method is, how it works, and the other benefits. And in so doing, the only way that you can do that is by you also make sure that the clients understand how it works, and this way it will dispel some myths and misconceptions. The other thing that I didn't perhaps quite emphasize on is about giving time for the client to ask questions so that you can clarify any areas that they may not understand, and also clarify some myths, rumors they have heard about the method by just asking the client, whether the information you have given has been comprehended, whether they have any concerns or any questions about the myths. And in our setting, we have done some work on community work and myths around family planning issues. And when we are in a certain area, we know what myths are common in that area, and we go up front. Like, for example, when you're discussing about an IUD, you'd tell you by showing how an IUD is placed in the uterus or in the womb of the woman. Then you emphasize that IUCD does not move. That is a common myth in many areas. And that's explaining, let me say, explaining and using the job aids correctly is one sure way of making sure that you dispel any rumors, any myths, and again, seeking for the client's comprehension about the method.
Yeah, thanks for that, Charity. And yeah, and while I have you, I want to follow up with an additional question specific to the balanced counseling strategy, and this is coming from Leah Jarvis, and that is, has Pop Council done any evaluation on the effectiveness of the BCS or the BCS Plus, and particularly how it's affected client satisfaction or the method mix, or where is Pop Council sort of in the spectrum of that?
We have done some studies on, on how, the the feasibility and acceptability of the BCS Plus, and also if clients, for example, comprehended or there was a difference when on the information that the clients had when the BCS was used. And we have done those studies here in Kenya, South Africa, and some in India, and there is definitely some results. I may not know the figures now, but in Kenya, I think about that 7% of clients said that they were aware of the methods and how it works much more compared to use of other family planning methods. Yeah, so we have done that work, and yeah, there is some information about how.
Sure, and also I recall hearing, I think, from other colleagues at Pop Council that I believe it's going through another iteration of development in the coming months. Is that correct? There's further development happening.
Yes, we are. That is very correct. We are looking at use of this BCS at even at the community level and with the providers, and also looking at updating it with the current, WHO.
Sure. Okay. So this will be to accommodate for the medical eligibility criteria, et cetera. Great. Thanks for that, Charity. We have a very active chat screen, so I'm going to go. There's been a variety of comments. So I know, Tembe from E2A has asked some things about, if people have seen any evaluations of some of the group client education and how that affects counseling outcomes. I know there was a correction made by Levent Kagate about the READY framework, and that it actually does have some features that echo that the first step, that pre-choice stage of the balanced counseling strategy. So there's sort of full descriptions of these in the chat window, but I'm trying to summarize some of what we're seeing. On the male involvement issue, Jane from Engender commented that that Engender is seeing that increased use of community dialogues and building male champions is helping on the male involvement side of things when it comes to family planning counseling. So next, I wanted to go into a comment from Jim Shelton, who comes from USAID, and Jim makes a really important point here, saying that his concern is that the underlying assumption is that it seems to be that we're assuming clients come in with a blank slate, but the reality is that the large majority of clients already have a pretty good idea of what they want, and most clients can use most methods. So their initial choice should be the starting point, and then the interaction should really be revolving around why they want that method and what other methods might meet their needs. But most importantly, how to use that method and what to expect. Again, recognizing that they're not coming in with a blank slate often. They're usually coming in with some idea of what they want to look at. And I think Jane, commented onto that sure enough, like how do we address these continuing users? And actually, I'd like to go back to Charity on this one, and just Charity, maybe you can talk a little bit about how when a client arrives and is faced with a balanced counseling strategy, what happens if they already have a method in mind, or if they're already on a method?
Yeah, thank you. Already have a method in mind. Yeah, thank you for that question. Yes, when a client arrives and they already have a method in mind, I think that is a starting point, and I would want to agree with Jimmy that is the way to start. But usually, even when they have a method in mind, the balancing counseling strategy is designed in such a way that they will also be able to see whether the method they are choosing, because a client may want a method, perhaps they have used it in the past, but there is need for you to review her current situation and using the BCS cards and the BCS tools to make sure that the method that she still wants is the appropriate one for her. And again, if she insists that this is the method, you ask her a few questions, in the pre-choice method, and you identify that she has no other problem. You do not waste a lot of time going through all those other methods, because she has already made up her mind. And this is why someone asked, what is the plus about BCS plus? This is one of the plus, that you do not have to go through all the methods, because she after asking some preliminary questions, you already know that she has qualified for the method that she wants, and then you go ahead and offer those other services and offer her method and counsel her for STI and HIV. And also, someone asked, what is the price about the BCS? Uh, Before the BCS price, or both the gather and the ready, and I want to also agree that these were not, these two approaches in counseling are not particularly bad, but the BCS plus is an improvement of those two methods. And this is the plus, where when you are doing gather in the 80s and the 90s, the issues of HIV were not very common at that particular time. But in the late 90s and in the 2000s, HIV counseling and testing is part and parcel of family planning consultation. We are talking about RH and HIV integration, and therefore the BCS plus, or the plus is that other than just talking about the family planning methods, the additional thing is the card also gives you an opportunity to discuss about HIV testing. It also gives you an opportunity to discuss other issues the client may have, may want, the cervical cancer. And the other plus also is about the postnatal care, that we all know that the family planning, as good as it is, it tended to only talk about family planning and reviewed very little about the child welfare, and also looked at very little about the postnatal examination for the mother and the baby, and so on and so forth. So when you talk about the BCS plus, this additional information is what we are talking about. And again, I want to reiterate, it is not that the gather and the ready do not do some of this, but the other additional plus on the BCS plus is also the use of these several job aids that guides you through the process. That makes it very easy for the service providers, and again, that is a plus for the BCS plus.
I think that was great. Yeah, no, I think that was excellent. I wanted to comment. There were a couple comments that came in as well from some of our participants. So Lee Wynn from FHI 360 commented that another great functionality of the BCS Plus is that it also identifies other potential methods that that a client might be interested in, even if their first choice isn't available, which I think, as we all know, is actually unfortunately all too common, that stockouts are leading women to not accessing maybe their ideal method, but the BCS Plus can be utilized to really kind of offer what's the next best for that particular client. There was also a comment from a field colleague in South Sudan. This is from Maryline. She said that she's used the BCS Plus method in South Sudan, and it was easy as health workers because you don't need to remember the details of every method. You can just read them from the cards, and she's combined the BCS Plus with community participation programs involving multi-generational community members, both male and female. So another great example of how to get male involvement. On male involvement, another comment, this one's also from Lee Wynn from FHI 360. And she comments that male engagement through radio programs and community dialogues is a great starting point, but also engaging them in early adolescent and fertility awareness education, so that girls and women, as well as boys and men, benefit from that knowledge across generations. Another comment, this one from Tembe again from E2A, and Tembe comments that myths and misconceptions at times contribute towards discontinuation. So counseling and that client-provider interaction should be going on during follow-up visits as well, to find out what the concerns the client has about the method are, and to reinforce the information about the method being used. So acknowledging that, today we talked a lot about what happens at that, that very first, or maybe not the first interaction, but the interaction where the client receives the method, but that there is sort of an ongoing relationship, and the providers need to be giving this ongoing support to users, such that they understand or have the ability to check in with providers about any side effects or any issues that they're experiencing with the method that they're using. And then we have another a question here from Jim Shelton, who's again from USAID, and he's asking how this relates to implants specifically. He says to him, priority issues are counseling on the bleeding, side effects, and the availability of removals. And certainly, as we mentioned in the beginning of the webinar, I think today we're focusing really on the entire method mix. But you're right that when it comes to implants, one of the most important things is giving sufficient counseling during the method choice stage, so that those more common side effects with implants, which are, as you've noted, the bleeding irregularities, don't come as much of a surprise, and that the client can have has some warning that might happen, and as Tembe has noted, that they can feel comfortable revisiting the facility if they feel like they need to talk to the provider further about that, and hopefully not discontinue the method unless necessary, but really become comfortable with what might be happening. Let's see, I'm trying to see if any of the rest of these are questions. We have a few more comments. It is now 15 minutes past the end of the time, and of course, this has been really interactive. I really appreciate all the comments and questions from everyone, and the time of our presenters, as well as those who are part of the Implants Access Initiative, including, I see we have some of our Merck and Bayer colleagues, we have our Gates colleagues, and others. We will need to close off from here, but I want to open this up to say that if there are any further questions, I'd be happy to receive your emails and forward them on to those who might be most appropriate to answer them. So I think you've seen my email, everyone, but I can type it again here in the screen. I'll do that right now. So if you have any questions, you can go ahead and just email them to me, and we can farm those out to clinical experts, or to Charity from the BCS perspective, to Trish for informed choice and counseling, particularly from USAID. And we'll try to get answers to those. So thanks again, everyone. This was recorded, so I will be sharing a YouTube link to this in probably next week if you wanted to re-listen or share it with colleagues of yours. And thanks again, everyone.